Okay. Good afternoon and welcome to this public meeting of the Standing Committee on Social Development. My name is Jane Wayellen Armstrong. I am the MLA for Mopi Clinton Region and Chair of the Standing Committee on Social Development. I will now ask the members in the room and online to introduce themselves for the record. Thank you. Starting with Kira.
Hi, good afternoon. My name is Kieran Tester and I'm the member for Range Lake.
Good afternoon. I'm Shauna Morgan, MLA for Yellowknife North.
Now to online.
Good afternoon. My name is Cheryl Yakalaya. I'm a member for the Decho.
Good afternoon. I'm George Nearsu, MLA for the Mackenzie Delta.
Thank you, members. Okay. Today we are joined by the Minister of Health and Social Services and officials from the Department of Health and Social Services to receive a briefing on medical travel. Please note, this meeting is being live streamed to the Assembly social media channel. I would like to remind all members and witnesses to direct all questions and comments to myself as chair and to wait to be recognized before speaking to help us have a smooth meeting. I will now pass it over to the Minister. If the Minister can introduce herself and her officials, and we'll proceed with the presentation. Thank you.
Good afternoon, Madam Chair and members of the Standing Committee. Thank you for inviting me here today to discuss medical travel. Joining me is my Deputy Minister, Joanne Chiquetto, Deputy Minister of Health and Social Services, Perry Heath, Assistant Deputy Minister, Corporate Services and Cultural Safety, and Tim Van Overloo, NTHSSA Executive Director, Corporate and Support Services, and as well my Ministerial Advisor, Ali Kincaid. I've heard from many residents about their experience while traveling for care and how the supports that may be available and the process used to administer those benefits are not working for some people in the Northwest Territories. I want to assure you that we are listening and we are working diligently to make changes that are within our ability to improve client experience when accessing medical travel benefits. Most recently, we have heard from this committee that there are policy or process barriers that may impact the ability of individuals to receive the support they expect while traveling for care. Although there have been changes to policies and processes that may minimize these impacts, we continue to hear that it is often not enough. One of the fundamental challenges in the Northwest Territories is the complexity of the medical travel benefits and the number of different insurance plans that are accessed by residents. For example, residents have access to medical travel benefits from employer-sponsored plans, such as those available to GNWT employees under the collective agreement, and those available to federal employees, such as D&D. Private third-party insurance, and insurance benefits related to WSCC. Each insurance plan has different eligibilities, benefits, and each insurer is responsible for their plan's administration. The NWT medical travel policy, Métis Health Benefits Policy, and the Extended Health Benefits Policy, as well as the federal non-insured health benefits, most known to people, NIHB, are benefit insurance plans that are administered through the Medical Travel Office. The administration of NIHB is challenging and complex, and it impacts a significant number of NWT residents. In the past couple of years, the department has collaborated with NWT Council of Leaders to initiate discussions with Indigenous Service Canada around the challenges of administering NIHB medical travel. At these tables, we have heard Indigenous governments express that they are interested in administering NIHB, but only if it's fully funded and the policy issues are addressed. Our discussions with Indigenous Service Canada have been in support of this shared principle. We have much work to do, and it must be done in a way that is transparent, sustainable, and culturally safe. As a department, we remain committed to improving medical travel for residents. Today, we have a presentation that will provide more context for how residents are supported and when they need to travel for care. Perry Heath, the Assistant Deputy Minister, and Tim Overview of the NTHSSA Executive Director Corporate and Support Services will take you through the policy framework and administration procedures that the Department and Health and Social Services Authority administer. Thank you, Madam Chair.
Thank you. Okay.
Thank you, Madam Chair. I'll start out the presentation, and then partway through, I'll turn the floor back to Tim, and then maybe close it off myself. Just a brief agenda. We're going to talk about some background around medical travel. We'll talk about some eligibilities, and then right at the end, Tim will give some operational context, and we'll give an update on where we are with that NIHB. So as the Minister talked about in our opening comments, medical travel is a travel benefit, an insured benefit, and there's multiple providers from that perspective. So it could be anywhere from your motor vehicle insurance if you get into an accident, WSCC, the employer-sponsored programs, for example, the GNWT or D&D, like the Minister talked about, or even third-party insurance. When none of these other insurance providers are eligible, it then turns to our medical travel policy. Our medical travel policy lays out a bit of a framework where we have benefits for low-income people, higher-income people, and then we have the extended health benefits, and then the Métis health benefit piece. The NIHB element is something that we administer on behalf of the federal government, and that's administered in accordance with their NIHB medical travel or medical transportation policy. Just a little bit of a conversation about the policy framework. The medical travel policy is an executive council policy, 4906, that authorizes the overall policy, and underneath that we have ministerial policies, ministerial medical travel policies. One that talks about the eligibility, who's eligible for it. One of the key elements in terms of eligibility is you have to be an NWT resident, you have to have a healthcare card. One of the key pieces, you actually have to have a referral. We've heard many conversations from people in saying that they had an incident in Edmonton or in another province where they had to access care and they didn't have a referral, and they were confused, but if they were an NWT resident, why the costs weren't covered under that perspective. And so it's essential to have that piece there. The other piece is it needs to be it needs to be approved, and the medical travel policy only applies to people that aren't covered by other insurances. So for instance, if you have, you get in a car accident and you have car insurance, then that would be covering. Current principles of our overall program, and the principles that exist in our current policy said that access to insured health services should be provided to maintain and improve the health and well-being of residents of the Northwest Territories. And the cost of medical travel should not be an economic barrier to insured health services. The key point in this sentence is the cost of the travel should not be an economic barrier. Predominantly, this program is for transportation, getting people from one place to another to access the care. And then the other one is medical travel should be transparent and accountable. This program, as I mentioned earlier, kicks in when there's no other insurances in place. Just a few updates. So we've, in 2019, we made a few administrative type style changes to the policy. We changed the co-payment amount, and co-payment is for people that are categorized as high income. Low income, MHB and EHB don't have to pay a co-pay, but the other people who are in a high income bracket would. That co-pay amount changed from 125 to 200. The overall definitions of what was low income and what was higher income changed. The threshold was $70,000 a year to qualify for low income. A combined income for a couple would be $85,000, and it would be over $100,000 a year for people who have a child living with them. The other things that we changed was in February of 2024, we made a formal delegation to the NTHSSA for the administration of the program, but we also made a formal change in terms of the exception policy. The exception policy is now administered by the department. I'm just going to turn it over to Tim.
Thanks, Barry, and thanks to the chair and thanks to the council for inviting the NTHSSA here to this public briefing as well too. The NTHSSA has a key administrative role. Perry just flagged the direction from the department for the NTHSSA to administer the medical travel benefit program. And so I'm happy to walk the committee through some of the key administrative components of that as it leads to administering some of the policy language. So to start, just a reminder that the complexity of people moving for care. And so part of the policy, as Perry mentioned, is there has to be a clinical referral. And so nothing really starts with the administration office until there is a medical referral. And those have to come from within the NWT and for insured services unless they are prior approved through the GNWT as a non-insured service as well too. And then again, the NTHSSA has a key role to not only determine the benefit eligibility of that request, but also to start to coordinate some of that travel arrangements as well too. Next slide. In the following slides, they're more for visual purpose, but I'll walk through them relatively quickly, but to really clarify that despite the complexity that Perry shared around how benefits are administered through the NWT, depending on who the beneficiary is and who the benefit sponsor is, majority of the benefits that come through the NTHSSA to administer through the medical travel policy are essentially in two categories from an individual's perspective. They are either fully covered, so an individual that's under NHB, EHB, MHB, or is determined as low income, essentially receive transportation benefits, fully covered, accommodations to the boarding home, which include meals, as well as ground transportation. The other category from a public-facing perspective or a client-facing perspective is if you are designated and identified as a high-income category, where you actually have to pay a copay, and your accommodation and meals are reimbursed at specific rates. So just to simplify, I guess, some of that complexity, there's essentially two categories from a client perspective. The several slides that you see here is further behind in the background on how we administer these policies to be recoverable and reimbursable from different benefit programs. So you'll see in this slide through NHB, the NTHSSA on behalf of the NWT Health and Social Services System is able to recover a copay for some of the transportation benefits over the airfare up to $400 for round trip, as well as the full cost of the boarding home. On the next slide, you'll see GNWT sponsored programs, EHB and MHB. The NTHSSA, again, on behalf of the system, is able to recover the copay, which is $400 round trip, as well as the full cost of boarding homes and accommodations. And the additional costs related to these, as with NHB, are at the cost of the NWT medical travel program. Next slide. The next two slides are low income and high income. So again, as I mentioned before, there's no recovery on behalf of the program from defined benefit sponsors under low income. It's fully costed through the medical travel program. And high income, again, as I mentioned before, most of this is fully costed through the program except for a $400 copay that the individual has to provide for flights. And just to mention, the majority of travel that we administer falls through the NHB program or MHB and EHB at a lesser extent. So for example, only about 4% of our travel that we administer falls under the high income category as well too. Next slide. One of the key administrative priorities and activities that we perform is to ensure that not only the transportation activities are covered and administered and coordinated, but also to identify if any non-medical escorts meet the criteria in the policy. And so really the first step that there's two categories of activity that happens for non-medical escorts. There needs to be a clinical role, so there's a clinical referral or recommendation for a non-medical escort. And again, these are recommendations made by different individuals within the HSS health system, as well as these could be different individuals have different experiences within the health system as well too. And again, a key component of our operations from Health and Social Services is to be patient-centered, so they're always looking for what is in the best interest of the patient. And so they'll make recommendations related to why a non-medical escort might be appropriate. The job of the benefit administrators is to determine whether that recommendation aligns with the policy. And so what you see here is the definition of what would be considered as a non-approval for a benefit for a non-medical escort. And the reason why there's that separation, instead of just allowing any clinician to approve a non-medical escort, is it allows for some consistency. So we're able to align all the recommendations against some type of principle or policy, and allows us to ensure that that consistency happens no matter who's requesting that non-medical escort. And it also allows for some equality. So again, we sometimes have a transient workforce that may not be aware of policy, may not be aware of how even the system works to the full extent. And so having benefit administrators look at these recommendations and apply it against the criteria that you see here, as well as apply it to historically how this criteria has been utilized or shifted, allows us to have some equality across the NWT for these types of activities. The next slide is a highlight of how we're organized from an administrative perspective. You'll see that there are medical travel administrative offices across the NWT, as well as there are certain ways that we process the type of medical travel request, whether it's for out of territory, in territory. We are continuing to improve this, and we've had a lot of recommendations from regional wellness councils, from the public directly around improving the ability for individuals to receive clear definition of what they've been supported for benefits, as well as getting their travel information as well too. And there continue to be changes in that area as well too. And on the bottom, you can see a little bit of a high-level process map, but just shows that there are many touch points that have to happen from the time that there is a referral to the time that the individual actually travels for care. And the importance of that is the opportunity for chances for that information to be delayed or chance for that information to be clarified happens. So we're trying to shorten the amount of touch points that we have related to approving and supporting people moving for travel. This next slide helps frame some of the common issues that we've heard. So again, these are for individuals, as Perry mentioned, that have a valid medical referral, have a prior approval, and are going to appropriate insured health services. So there are a lot of common issues that come related to what is defined as a valid medical referral, what is a prior approval, and what is an appropriate insured service. But outside of that, if an individual meets those categories, some of the common issues that we hear are, as you may be aware, escort decisions. There's some medical referrals, the administration of the transportation and booking the actual transportation, so being able to be flexible when you leave and when you come back are some of the key areas that we do here. And you'll see throughout here, there's some very clear administrative questions that come out of here, but there's also some very clear policy questions that come out of here. And so that's why, as an authority, we have to partner very closely, not only with the GNWT and through the Department of Health and Social Services, but we also play a key role as a partner with other stakeholders, including the federal government through the NHB benefits as well. And I'll turn it over to Perry to take us through the rest of the slide deck.
Thank you, Tim. So just moving forward about where we go from here, the minister talked in her opening comments of listening to the and what's happening. We are taking that information and building a bit of a gap analysis around the state of the medical travel policies. We're looking at the escort criteria that Tim to talk about. We're taking a look at the per diem rates. We're looking at the long-term medical travel policies, like things like medical relocation. When does that happen and how does that happen? And the intent around that gap analysis to pull together a policy paper that talks about all these things and what the implication of changes are. Right now, our program isn't fully funded. We've talked about at length about how we are subsidizing some of the benefits that Canada is doing and how that's impacting our ability to run our medical travel program. So the intent is once we get those policy options pulled together to use them as a part of engagement with Indigenous Governments Standing Committee and other interested parties to talk about those implications and what the cost impacts of those are. Just jumping right through it, we talked about NIHB in the beginning and just a little bit of an update where our work is with NIHB right now. We were successful in signing a new agreement for 23-24 and 24-25. The amount of that agreement was $47.1 million. 22.9 of that was directly related to the NIHB program delivery. 24.2 was earmarked for a special purpose allotment, how Canada described it, to help us deal with the pressures that are outside of their clearly defined criteria. The challenge with this funding, and it sounds wonderful that we got all this extra money from Canada, but in 23-24, we were still close to about $8 million short. In 24-25, we're expecting to be double that short, double the amount than we were last year. Part of the reasons for those costs is the actual cost of medical travel, the airline cost. Last year, we were lucky in that, in the first half of the year, the travel wasn't as high as it was in the second half of the year. But predicting a year of the full amount, same rate of travel we traveled at the end of last year, going forward, puts us in a significant deficit. So where do we go and what's our conversation with Canada? Well, right from the get-go, it's advocating for full cost recovery for the NIHP program, for them to cover the full cost of whatever we're delivering. The impetus behind that is we've heard from multiple Indigenous governments that they think they can do a good job of delivering this program, that they understand the pressures in their particular community, their particular region, but we're not in a position to be able to hand the burden of a deficit program over to them. So the intent is if we can reach an agreement with full cost recovery, it's a springboard for other groups to take over administration. We're targeting an agreement in principle in September or the fall of 2024. And that agreement in principle will also be a bit of a springboard to address policy issues. The policy issues with NIHP stem right on back to 1988. They're not going to all happen overnight, but in the agreement, in the framework, we're actually going to have a process to be able to iteratively change the policy and update it with Canada and make improvements going forward. That's all I have for you guys today. Turn the table back to the chair for questions.
Okay. Thank you for the presentation. I will now ask members if they have any questions. MLA Morgan.
Thank you, Madam Chair, and thank you for that presentation and for sort of summarizing it in a succinct way, but I know that there's lots more detail in there that you guys could provide. My first question has to do with, so emergency medevacs, I know is not under the same kind of policies as medical travel policy in terms of escorts. So especially when it comes to, say, people who are in life-threatening conditions and they're being medevaced, say, to Alberta, and there might need to be, end-of-life decisions that need to be made once they get there. What is the policy, or are there any circumstances under which escorts can go with that person and help, or is that being reviewed or looked at? I've certainly heard from both constituents who are patients or family of patients, but also from physicians who also feel that it would be really important to have close family members there when someone is in a life-threatening condition or you have to make an end-of-life decision. Thank you.
Minister of Health and Social Services.
Thank you, Madam Chair. And, you know, that is one of the more common issues. It is the emergency medevacs. And this is where we're saying it's very complex, the medical travel piece, because if you are being sent out on a medevac, it doesn't activate the medical travel policy. And so what ends up happening is, you know, there's a request and physicians usually, because there's no process and there's no policy, they'll write letters. And this is the one of the issues is that they're advocating on that this is the gap that we're seeing. But the complexity of it is there are times where if it's a non-insured health benefit person and the request is put in, that's an exception that's made in NIHB in Ottawa to approve that. And then that gets approved by them. And then because there's an approval, it goes to medical travel, they are eligible now to book that family member and they can stay in a boarding home and they can be there. But because our travel policy only covers the travel costs of getting somebody to and from an appointment, and if they don't fall under that and they're not approved through NIHB, there isn't a mechanism, like we don't have a policy. So that's the gap right now. I can turn it over to Tim if there's anything that I've missed out of that. Thank you.
Mr. Van Ober.
No problem. Thank you. So the first thing we have to do is just determine, as we mentioned before, who the individual is and which beneficiary program they would fall under. And the second thing to note is to actually, a medevac is an emergency services, so they're typically going without notice and right away. And so one of the key things is we can't put escorts on the actual air ambulance. It's only very rare cases where there'll be eligibility for an individual on the air ambulance. And so part of the medical travel policy, as we mentioned earlier, is it's there to ensure that the individual can get to that care, be transported to that care. And so through a medevac, they are getting to care. They will likely be an inpatient. There is continuous discussions that happen once the individual arrives to their site where they're getting that up care, and a determination if there's a need for an escort that meets the criteria on the medical travel policies. So there are several cases where people are in inpatients and then are about to leave the hospital where they would need an escort, and we do fly escorts down for that, non-medical escorts. There are cases where that initial medevac turns into an initial life-threatening diagnosis or another diagnosis which fits under the policy, and so we do fly in non-medical escorts for that. But it really truly is case by case, and it really determines based on the benefit program.
MLA Morgan, do you have a follow-up?
Yeah, thank you for that. And let me see if I understand correctly. So I understand that you can't just put an escort on the air ambulance with the patient, but you're saying at that point, a family member could reach out to like the medical travel staff and see if they're eligible under any of the criteria under the existing policy where they could go down. And it sounds like there would be eligibility, obviously, if they're under NAHB, but if the person's about to be discharged, say they're an inpatient in Alberta, if they're about to be discharged at that point, a non-medical escort could be sent down. Are you saying that if they are in a life-threatening condition, that is an acceptable criteria to send a non-medical escort down? And I guess the follow-up question to that is, are these policies being reviewed to see if they're adequate around these sort of emergency medevacs or life-threatening conditions? Thank you.
Okay. Minister Simler.
I'll turn that over to Mr. Van Overloo.
Mr. Van Over.
Thanks for the clarifying question. The short answer is the current policy has eligibility criteria for non-medical escorts that I don't believe describe exactly the criteria that you're asking about. So they would not be allowed to have a benefit for a non-medical escort in those cases. But again, it's always case by case that we deal with. And there are also a lot of times discussions that happen with the care team, as well as the individual, as well as the individual's family as well too in those cases. So it's not the onus of the individual to request a non-medical escort in those cases. There's typically a conversation that's happening with the care team around the availability of a non-medical escort in those scenarios. And then there's a request to medical travel team, whether or not that applies to the policy itself.
Thank you. MLA to start? Oh, okay. Sorry, I do apologize. Minister Sidmar?
The Deputy Minister has some stuff to add as well. Out there.
Thank you, Minister. Thank you, Madam Chair. As you can tell, it's really complicated, and so we would have policy that is principle-based in this scenario. So every single situation, as Mr. Van Overloo has shared, is we would never be able to have a policy for every single clinical situation. So the key to this, I think, which is best to understand is from a health and social services perspective, our priority is the person in care and to ensure that they're getting the care that they need. And so typically, as noted earlier, during the actual medevac, the reason an escort is not on that air ambulance is because care is being given and the priority is that individual to make sure that they get the best care possible. And so, yes, so when they are where they arrive, as Mr. Van Overloo had noted, each of those, it wouldn't be the responsibility of the family to need to contact medical travel, because behind the scenes, while that individual is being transported, there is the care team from the home community that is also involved in this scenario. So they are working from a clinical perspective as well to determine if and or when a non-medical escort would need to be sent down with that individual that is in care. So I think the piece that we're trying to make sure that folks understand is, while we have policy for what would typically happen in these scenarios, there are circumstances where each clinical situation requires different decision-making. And so that is the conversation that happens between the care team, where the individual is being medevaced to, as well as where they've come from within their home community. And so sometimes those the decision around that non-medical expert is often linked to the case-by-case scenario related to the clinical care of that individual. So hence the reason we would not have a policy for every single one of those circumstances.
Thank you. MLA to start?
Thank you. So I wanted to follow up on my colleague's question, because I have at least 3 constituents who are dealing with this situation of a critical care incident that has led to them requiring to attend to their loved ones in Edmonton and who have been denied medical travel despite the support of their care team. And I think in both cases where the current policy allows for exceptions to be made for non-medical escorts around initial diagnosis or an initial appointment for a life-threatening illness requires a non-medical escort to assist with understanding a plan of care. So these wouldn't fall under that, but they're very similar in that if you need someone to give you, end-of-life instructions or something along those lines, like that's how serious these cases were. Thankfully, everyone was able to recover, but now they're saddled with significant financial cost. So if we are adjudicating things on a case-by-case basis because of the galaxy of medical issues that prevents kind of single policy thing, like how do we help these people? Because it comes off as arbitrary at the end of the day when you have your doctor, your nurse, all these people pulling for you and saying, we're trying to help, we're saying this person needs to be here, and we're advocating to the medical travel coordination unit of the department to get the exemption for you. And then the administration comes back and says, no, we're not going to do it. And that's where I think the disconnect for people are when their caregivers are telling them, we agree with this, we are going to go to bat for you. And then MLAs get involved, and I know the minister doesn't want MLAs get involved. I don't think MLAs want to get involved. This should be something that can be handled by policy. But as long as it's going to be case by case, and as long as we have non-medical personnel being the final decision makers, I think you're always going to be in the situation. So how can we improve things? Because right now, it feels much more arbitrary than I think you intend it to be. And I think it's the disconnect between the medical professionals and the administrative professionals. Thank you.
Minister Similar?
Yes, thank you, Madam Chair. You know, and as a past medical profession, and I'll be honest, you know, knowing that we had medical travel, I don't think as a medical professional, I actually sat down and took it to account as to what it actually covered. I just thought it encompassed everything as well. So being fully briefed and emerged into this policy and having to have these discussions ongoing with clients and trying to navigate all of the different insurances, I think that is the problem, is there's such a, like we've discussed all the different insurance plans, and so where you fall in, and if you don't fall into an insurance plan and it becomes where it's the NWT medical travel, the medical travel policy is for the patient. And you know, and if somebody is medevaced on an emergency and there's life-threatening concerns, that's still the patient is the center. And it's you know, and I this is why I said there's this gap when we have a loved one that's down in Alberta and they're in the hospital. Of course we want to be with them, and then, you know, the physician's there and it's like they agree, I agree, you know, that somebody should be there, but our policy doesn't have that. And I think the thing is that it's, I mean, everything that we do has to be approved in, you know, in a way that we bring forward the business plan. And if this is something that we're going to do, and if we're going to be applying an escort for every inpatient that is in Alberta, and this is the criteria, that is going to be a significant cost to the GNWT, which I totally understand, but we're looking at a health authority that has a $640 million budget. And, you know, if we're going to be adding on an additional $40 million for escorts, you know, so that's why I think right now we don't have, and I'm not trying to be heartless or careless, because I know, like, I've had my own family that has to go from Inuvik to Edmonton, and so where they are is that there is no policy for that. And that's the problem, is we're trying to fit them into where the travel policy is to get them to and from the appointment. That's why when MLA Morgan says, we'll send you down so that you can return. And if they're, and one of the things is that I guess this is my frustration now, is that when we're advocating to a family member, this is not, we don't have a policy for it. So if you're going to travel on there, you could be on the hook for that. And, you know, and that is our own staff making sure that they're aware of that, that if you're writing a letter, it doesn't mean that that's going to change it, because it may not fall within the issues. And then once we get the medical condition and the patient is alert and awake now, whereas yesterday when they were medevaced, and now we're looking at the approval that they're alert, they're awake, and they're just going to have to stay in the hospital for 2 to 3 weeks, then it doesn't meet that policy that, you know, for the escort. So things change over time, and then we have to, so that's what ends up happening. I guess I can turn it over to Tim or Perry for anything else that I've missed on that.
Yes, Mr. Heath?
Thank you, Madam Chair. The question is, will we be reviewing that? And that's the whole point of the gap analysis and the policy options papers, to come back with those, if we're going to get what we would describe somewhat of a compassionate policy, to understand what the implications of that are, to reach out to interested parties and say, okay, we've heard, we've listened, we've pulled it into the policy options, and this is what we think the implications are. We can go now forward understanding what the implications and what the cost would be, and we can make decisions based on that. That's the whole point of doing the option analysis. Thank you, Madam Chair.
Thank you. Am I late to start? Do you have a follow-up?
Yes, well, so that's good that we're going to do that, but, you know, your analysis could come back and say, no, that's too expensive, so we're not going to do it, and that doesn't help the people who are representing in these very specific circumstances. And I think where I struggle with it is if someone has a stroke and they're medevaced out, and then they're on a ventilator, and, you know, their partner doesn't have necessarily the means because they're a retiree, for example, or something like that, and they're told, we're not going to cover you, you can zoom in and see your loved one, and we'll hold the computer up, which, you know, was an option presented to one of these people. That doesn't sit well with me, and if we are adjudicating things on a case-by-case basis, I don't know why we can't have an exemption for that specific case when someone, you know, could be in a terminal condition and their medical team is saying there should be someone here providing that advice. These are not hypotheticals. These are things that have happened to people. And I'm not sure why we can't build a policy out around that very specific thing. You know, we're talking about life-threatening or end-of-life decision-making. And if we don't have a medical travel policy that accommodates that issue, we should at least put something on an interim basis. I don't think these things are happening, you know, well, I guess I'm dealing with 3 of them, so they do happen quite frequently, but I think we should have a policy for that. And as our population ages, and as, you know, we struggle to provide the same level of service for some of these issues that you can get in Edmonton, we're going to see more of these, not less. So I would suggest we get ahead of this, and when you're doing your analysis, you take that into consideration, because it's unconscionable to me that we are putting people in that situation and then sticking them with a bill. Thank you.
Minister, similar?
Yep, and that's why we're reviewing it, and I mean, case by case, yes, there are some that are approved, and as I mentioned, majority of those ones, and I can't give you the numbers, but I'm almost sure that they would be NIHB clients that are the ones that are being approved for that, because NIHB will make that exception through their policy, and then so once they make that exception, then they do that. And so for us to be able to make that exception, we need to know what the cost implications will be like, and that, because those are the things that we continue to have to watch closely, as those are things that we have not budgeted for, and those are the things that drive up the deficit in the healthcare system. Thank you.
Thank you. Now I go on to MLA Yakalaya online.
Good afternoon. Thank you for that presentation. Going back to what MLA Morgan and Testart talked about, the need to review or probably look at the medical travel policy, and the scenario he talked about the end of life, where you have family members watching or talking to somebody who's passing away on a camera. And that too doesn't sit with me well. I sat with a family that went through that. It was very sad. It was very, I couldn't believe I was actually seeing this. This was actually happening, and that they couldn't be with their loved one in Edmonton when she passed away. The children and the grandchildren, and we're on a video link. And so, having said that, and also dealing with a young individual that passed away a few weeks ago, that had an accident in Edmonton and was denied medical travel or denied any. I don't know how his care was covered. I don't know that level of detail, but looking at that and thinking about how we need to, Minister was speaking to, there was a problem of this, a problem of that. So I think that's something that we have to review and see how we could change it. Another thing I wanted to mention was you had a special purpose allotment fund. And is that to cover any special cases for, say, the individual What does that special purpose allotment fund do? What is that for? Thank you.
MLA Similar? Minister Similar, sorry about that. I do apologize.
Thank you, Madam Chair. Madam Chair, the special allotment, so over the years, the one thing that GNWT has been, when we say we've been not fully funded for administering the NIHB program, is that the NIHB for insured services, so that includes like all of the health stuff, we've only been able to be reimbursed through the federal government, the copay. So they will only reimburse us the copay. So, knowing what it costs to travel from Inuvik to here and back, and that, it's not covering the whole cost. So GNWT has been having to pay for a lot of that insured services up until now. And so the way that we, in the negotiation, and I can turn it over to Perry to be able to explain how they had to go with, I think it was one agreement, but there's two separate pots, one for NHB and then the special allotment, to be able to come up with, to figure out that deficit that we have been occurring. So if it's okay with you, Madam Chair, I'll turn it over to Mr. Heath.
Yes, Mr. Heath.
Thank you, Madam Chair. So the special purpose allotment is basically to cover the shortfall, or a portion thereof, the shortfall that the Canada is underfunding that program. So as the Minister talked about the copay, so right now the cost of an airline ticket, for example, and in that cost, NIHP pays for $400. If that ticket happens to be $2,000, the GNWT pays $1,600. And IHB only covers the $400. That special purpose allotment is intended to offset that cost. Last year, we thought we were going to get close to Canada covering the full much of that offset, but we weren't. We ended up being about $7 million short. And as I mentioned previously, this year we're predicting probably double that if we don't get, if we're not successful in getting a new agreement in place soon enough. So it is those types of costs that we, i.e. the GNWT, end up bearing, and that was the whole concept around the allotment. Ideally, the concept is full cost recovery, is that when they get a $2,000 airline ticket, they cover 100% of that airline ticket cost. Thank you, Madam Chair.
Thank you. MLA Yakalaya, do you have a follow-up?
Yeah, that's a good one. So when do you anticipate this new agreement to be in place? Thank you.
Minister Similar.
Thank you, Madam Chair. Madam Chair, we signed the agreement just before March, I think, March 28th of this year. And that actually, because if we did not, we were at the 9th hour, that if we didn't have an agreement, NIHB would have been fully on us because we didn't have an agreement in place for the last fiscal year. So I think it's 23-24 and 24-25 is where we signed that agreement for. And that's why the department is working. We met with the Minister Haidu just in May, and we had got an agreement that our department is working in collaboration with their department, is that we are going to, until I think hopefully by August, late August, that we will have an agreement that will give us 100% recoverable. And also, the other piece of medical travel that we continue to hear about is dental, is to be able to resolve the piece of dental in the Northwest Territories, because that is what's driving up the cost, not the cost, but the amount of travel that's happening. It's filling up our boarding homes, it's filling up the planes. So there's, and so people that are going on dental, those get approved in Ottawa. We don't have the authority to approve dental approvals. So when a dentist, you make an appointment, the dentist sends it in. If they don't approve it and send it back to medical travel with an approval for that appointment that it's covered, we cannot book the travel because we know we're not going to be covered, right? And we can't, and so that's the big frustration as well that's going on. So this agreement is going to compile all that, and so we're hoping that we'll have an agreement in principle by the by the end of August, so that way we can make a decision whether or not we're going to continue to administrate NIHB on behalf of the federal government.
Thank you. MLA Yakala, do you have a follow-up?
Yeah, that's kind of alarming because you look at whether or not we're going to continue to administer and medical travel on behalf of the federal government. That's an alarming statement almost. So, is that what I heard? Is that correct?
I do apologize, Minister Sumler.
Yes, thank you. And why it is an alarming thing is that for so many years, we haven't been fully recovered for this funding. And so it is costing the GNWT every year that we administer this program on behalf of the federal government, that they aren't fully covering the cost of it. It's costing us. So that's money we can put back into other programs. That's money that's, that's driving up our deficit. Those are dollars that this is a federal program. And so this is at some point, do we continue to just administer it, or do we turn it back over to them and they administer it on behalf of the residents? And this is what's been happening for so many years. Like, if we did not get this new agreement with this special allotment, we were running 35 million deficits in NIHB. So thank you.
Thank you, Minister Sumler. George, MLA Nursu, do you have any questions?
Yes, good afternoon. Thank you for the presentation. I just have one concern. A few years back, I went for surgery in Edmonton to remove a tumor, and they did not send an escort with me. And I stayed in the hospital for 10 days, and I don't know if anybody ever stayed in the hospital at that length. And I think I just lived off fruit because I couldn't eat what they were trying to feed me, and I lost a lot of weight, and I had to walk with specialized crutches. I stayed in the hospital for 10 days because the boarding home were not equipped to take care of me. So I had to stay in the hospital, and I had to fight for someone to come to me. So after 10 days, my wife was actually able to come. So I went to the airport with the driver, and we're waiting where the arrivals coming. We're waiting there, and I was on my crutches, and my then wife, she walked right by me because I had lost a lot of weight, and she didn't recognize me. She walked by me, I had to call her, and she turned around and she almost cried, and she said, "What happened?" And I said, "What do you mean? I told you I was going in surgery." She said, "Why do you look so thin?" And that it's because an escort wasn't with me at the time. And these are circumstances that some of our residents are going through. Just recently, Charlie Furlong called me, and he wanted an escort because he is going to have surgery on his eyes. And after surgery, he was going to have his eyes covered for a few days, just so he can heal the process. But he wanted his common-law, who resides part-time in another region, Fort Liard. And his common-law knows his medical history. They've been through this process before. He's a surviving cancer patient. So she knows all his dietary limitations, what he's allowed to eat, and what medications that he takes at different times. But he was denied because he was able to travel down to Yellowknife on his own, but he was denied because the escort was not traveling from Inuvik or Aklavik to his hometown. So, is there any circumstances where someone who knows the patient's background, medical background, good enough to give comfort to the patient to be allowed to be able to be an escort? Thank you.
Minister Sudler?
Thank you, Madam Chair. I can't speak to any specific cases, but with medical travel, the medical travel policy is clear that it's to assist in the travel. So if the person is traveling from one community and they need an escort, then that person should be traveling with them. It's to provide assistance during travel. Thank you, Madam Chair.
MLA Nurse, do you have a follow-up?
Yes, thank you, Madam Chair. Just clarification, I was given a written notice that if the patient was able to go to the appointment on his or her own, that, and I specifically stated that, the patient would need aftercare. And like, it is similar to my circumstances because I was down there alone. I had a cast on my arm and on my leg, and I had 2 different types of crutches. And I was there all alone for 10 days in the hospital. And, even for a short time for an elder to be this, I think, there's a lot of concerns about medical travel, escorts, and issues surrounding this circumstance. It varies within my region, probably being one of the furthest places to have to travel other than Tak or Nanakput. So, it's very difficult, especially in this time of the year when you have to travel from Fort McPherson to Nuvik, and I tried to, myself, I go on the radio with my CA try to go on a weekly basis, and we try to give information on how to better assist our residents of the Mackenzie Delta on services that's provided through the government, especially health, if they're going for health-related reasons. Excuse me. In the future, like in a month or so, don't wait till the last week to try to get things organized. Do it now. Like do it a month prior. So if you're denied something, at least you have the process of doing the appeal. And that's what I stated in this case. He gave me 3 days notice, and I really tried. I tried throughout the days. I tried to get him an escort. He appealed it, and by the time the appeal came back, he was done his surgery, and I didn't even know. So that's more of a comment. It's, I try to look after my residents, my constituencies. I try to look after the well-being, and I know the policies of the Health and Social Services Department varies, but I feel for these guys sometimes. I know their first intention is to be mad at me because they elected me to look after their well-being, and I try to work with the ministers in the various departments, and I thank them for their openness too. So, but it's more of an educational matter for me to get to know that, let them know that there is procedures and policies that we have to follow. So hopefully we can work together and, make our residents feel more comfortable and not be sent down in a circumstance where they feel lost. Like I was lost when I was down there. So it's more of a comment than anything. Thank you.
Okay. Thank you. Thank you, MLA Nursu. Minister Semler?
And yes, and I guess where the issue is that if it doesn't fall within the criteria, we also have, there's an exception I think it's the exceptions policy, which then that, triggers another review, but that review is done by the department now. We've removed it from the staff that are actually looking at it, so it's like another level. The NTHSSA is where medical travel and the staff sit, and then the exception policy comes at the department, which is separate from the NTHSSA. And that kind of gives it a second review to say, is this something that, that we would approve? But unfortunately, many times people don't use that venue, and then and I think this is where I'm learning. This is kind of what we're trying to do as a department is, and through my office is, if you're going to the MLA, and I hear the MLA nurse who says, he's there, he represents his constituents, but it's providing them with the quickest way, and if the exception policy is submitted immediately after their denial because it doesn't meet the criteria, then we can look at it and hopefully we can, resolve it before and have an answer to that member. Because in different circumstances, maybe it means somebody else is an escort, or you make connections with family members that are, there to support you when you get there. Or, and this is another area that we are looking at, is how do we support, if family can't be there and there's no escort, how do we support and be culturally relevant and safe when somebody's traveling to another community? So that is also part of something that we're reviewing. Thank you, Madam Chair.
Thank you. Thank you, Minister Semler. I do have a question too as well. I know that through the presentation, you, I think the staff have said it too, and you said it too, medical travel is for patient and priority is a person in care. Sometimes even though the medical practitioner or, the doctors, they give approval for medical travel, for escort. And sometimes, maybe it's due to the bureaucracy or the time limits or time difference with the, with Ottawa office. Sometimes the medical escort does not arrive at the other end. So that's a major issue, especially for those with language and mobility issues. And it is a nightmare for many, just like Mr. Nersu said, it's a nightmare for a lot of them, especially with a language issue. So I'm just wondering, part of the policy review, if HSS or, Department of Health are working with the Indigenous government to possibly transfer the medical travel to the Indigenous government to administer. I just want to know if you guys are working on that, or did any of the Indigenous government express interest in administering, medical travel? Thank you.
Thank you, Madam Chair. Madam Chair, before I was the minister, there was a presentation done to the Council of Leaders, which is made up of many different Indigenous leaders throughout the Northwest Territories. At that time, many of them were saying, we'll do it, we can do it better, because we're hearing all the complaints and the concerns from our residents. But until they had the presentation and knew that how underfunded, how much we were covering for that program, they were like, okay, we'll change our scope. We'll get behind you now. And so that was part of even when traveling to meet with Minister Haidu, Indigenous leaders came with me to be able to reinforce that, this is something that we could draw down and we want to for our people, but we need to make sure that it's 100% recoverable. So if we're going to do this program, and so that's the work that the department, Mr. Heath's team is doing right now, is working with ISC to try and ensure that the future agreements can, that we can work out all of those issues that you've mentioned there. And so that way, if an Indigenous government wants to take that on, that they can. The other thing is that we also want to make sure that we want to raise the issue, and I think that is what's the, what you're saying is, I think the Council of Leaders were loud and clear when they met with Haidu. My very first meeting at the very beginning of this government was that people coming from small communities, especially Indigenous and elders, and it doesn't even need to be elders. It's if you've never left a small community of like Toledo, for instance, and you're going to the U of A is bigger than Toledo and probably has more staff than the whole Sawtoo working in the U of A. And so we need to make sure that we have an agreement with NIHB that those types of escorts could be approved in a quicker manner. Like you said, they work 8:30 to 5 Monday to Friday in Ottawa. They don't have after hour or weekend or anything. So if you're seeing a practitioner on a Friday and they're saying you need to travel Monday, you may not, and they need an escort, you may not get that approval for that ticket to fly out on that Monday, right? So that is, and we are fully aware of that, and the team is communicating that those things need to be resolved. We don't have the control to force them to make those approvals faster, but is that something that they can delegate to us within a criteria so that we can make those, so that we know that they'll be reimbursed, those types of things. So thank you, Madam Chair.
Thank you. Another one, okay, there's that, the federal government and territorial government, they have a better medical health care system, okay. And for the rest of the other population with no insurance, okay, they're the one that are losing out a lot in this whole process, especially with the medical travel. And I know that in small communities, well, you come from higher, from Inuvik region, and it's more expensive over there. So with the high cost of living, especially in the small communities, things are expensive. We know that, everything. So people don't plan for holidays. We don't plan for holidays, especially living in the small communities where every day is a living for us, where, somebody has to pay for the rent or mortgage or groceries, and that's everyday thing for us. And that holiday, I don't think that's beyond many of our small community members' vocabulary. Except for living in the small communities, we see teachers and other professionals, they go on holidays because they have their summer break, so they do plan. But for a lot of other people living in the north, we don't have that, luxuries. And when people do travel, or if they do make a trip south or something like that, it's always through an organization or through a business, or they piggyback off meetings and bring their families, and or spring break, especially spring break, like small communities with the road access or with the ice road access, they do take advantage of that. And even like I know Desho had an issue with that last with one of their constituents, and even this past winter, one of my constituents, a family with a young child, they traveled during spring break to the south, and their child got sick. And in the process, so the family were, in Edmonton for a whole month. Oh, actually, no, it was in one of the community, actually it was in Grand Prairie. Now the child was medevac to Edmonton. So the family are still, they're struggling still. They're still trying to recover from what they lost. That child survived, so which is good. That child is okay, got the best medical attention in the south. But it's a burden, especially in the small community where you're having, it's difficult to make ends meet, and they're still trying to recover from the financial burden. So I'm just wondering, or maybe part of the policy review, if they had access to a good medical plan, everything would be covered, but they did. So would part of the review, I know they're not eligible for Larga, to stay in Larga because they were not approved. So can we change the policy, or can that be part of the policy review where you open up, Larga, especially to family who find themselves in this situation. And I can tell you, many of the communities, small communities, don't have house insurance. They don't have medical insurance. They don't have life insurance. So now we're asking them if the airlines, yes, they say, like, do you want insurance? So, okay, you buy that for $20 or, but for travel with their own personal vehicle, nobody planned for those things. So we don't plan, people don't plan to get sick on when, we don't know when people are going to get sick or not, what kind of illness they're going to get. So that's a burden as well, like having to access medical or travel insurance. So I'm just wondering if, I hope the Department of Health and Social Services will look at it and make it part of their policy review, that maybe open up LARGA to some of these people that, like my constituent found themselves in that situation. They were in Edmonton for a whole month and used up most of whatever they had, So I'm just asking about that. Thank you.
Thank you, Madam Chair. And I understand. And I think travel insurance is, even for myself, I don't think I've ever traveled in Canada and bought travel insurance, because I've never thought of it. If you're leaving the country, you've always, people will buy travel insurance when they're leaving the country, because in Canada, we have universal health care, that you can access the healthcare system. It's the medical travel piece that is not that doesn't go along with your health care card. And that's why it's, and so when people are traveling, and I hear you that some of them don't have this, but there are for if they're, if you're planning a vacation with your family, even if you're driving, you could purchase travel insurance. And you can, most people have smartphones nowadays. Most people have access to, and if you're living in a small community, majority of people that, even a lot of seniors now are getting their technology, they're getting a lot better with. You can purchase a lot of the travel insurance for your family, and that will cover you. If something happens, it will cover you for your expenses, your delayed, for a certain amount, even for your medical expenses, if they're outside of what's covered for. If there was a medevac, in jurisdictionally, like you said, if somebody was medevac from Grand Prairie, it would cover that. And that's why, I think that's one of the things that, we even now are trying to put that information out there for anybody who's traveling from their home. That's why you buy insurance, because you just never know when you're going to get sick. You never know when you're going to, you have fire insurance, you have vehicle insurance, because you don't know if you're going to get in a car accident, right? And unfortunately, because those bills are usually large it's a large amount to recover. But in saying that, coming from small communities, if there are certain issues or certain things that happen, we can review all of these things in the review that we have to see how many people is this actually impacting, how many requests are we actually are getting on these things, and how much would that cost us, and if that's something that we as a government, will want to cover, if we see it's in a significant amount in this area and it's the right thing to do, and are we going to cover that as a government? Thank you, Madam Chair.
Thank you. We still have time for members to ask second round of questions. So I will go with MLA Yakalaya. MLA Yakalaya, do you have a question?
Thank you. I was talking about the travel medical insurance. I think it's more of a statement that I will make, is that we should encourage, as all MLAs, we should encourage all our constituents to now get travel insurance, even if they go to For me, in the Detroit region, we have people that travel to Edmonton or High Level or wherever just for the weekend. People should really get insurance. doesn't seem like when people get hurt overseas or something happens overseas and the federal government sends a plane to pick up people like that, that like how does that work? It's not a medical thing. It's just a safety thing for the people. So thinking about that, it seems like that's a priority more than a medical insurance. So having medical insurance for our constituents is the way they have to do now. If this is the way the system is operating. So for me, I guess I'm going to start encouraging people to get medical travel insurance because of the way that my constituent got hurt and ended up passing away in Edmonton. That was a very difficult thing. So it's more of a statement I'm making. So just and if the minister wants to respond to it, that's okay too. Thank you.
Okay, thank you, MLA Yakalayo. Minister Sundler, do you want to respond? Or?
No, and I think that's our responsibility. I think as MLAs, when we have and that's why I think when this issue was brought up in the House, it's a very unfortunate issue, and in my community, a few years ago we lost many homes and some weren't insured, and and it's an unfortunate thing. We talk about. One of MLA Yakalaya's communities, and a lot of the members lost homes and they're not insured. And these are really unfortunate things. And so that's why the department and I shared that information with all MLAs to be able to provide to their constituents that, not just traveling out of the country, but leaving the territory or leaving your community. Just, if you were to within the territory, you're covered within the territory, but once you leave, but even if you're from the Sawtoo and you come into Yellowknife and you get sick, and you're going to be medevac back to the original place that you came from. So even if you were medevac from here to Edmonton, if you got sick or something, they would bring you back to Yellowknife. You'd still have to get your way back to your home community because you got yourself to Yellowknife if it was a vacation or something. So that's why I think it's important that people do look at that, because travel is a lot more expensive. Before I was saying this with a member, before we would say, it wasn't so bad because we could just. I remember being in Inuvik and jumping on the plane to go to Yellowknife for $250, and you were on a standby ticket, and you could come back and forth for less than $500. That's not the case anymore. And so the costs are so high that, to get yourself back home, if that's not a plan, then it's really important that you consider those as part of your, expenses that you're going to be incurring during any kind of travel. Thank you.
MLA to start.
Thank you. One of the principles of the medical travel policy is that medical travel should be transparent and accountable. Can you explain how you are ensuring that that part of the policy is being followed? Thank you.
Minister Sundler, sorry about that.
That's okay. So that is why it's important, and and I think this is the frustration of many residents of the Northwest Territories, is we're trying to be accountable to the policy, and so when the denials happen, it's because that's the policy. And as for being transparent, we're following the policy. There's the medical travel report that is done and it shows how many people are traveling, a year, how many escorts are traveling, what benefits, like if it's an NHB or, what are they traveling under? I don't believe on if I can pass it over to Mr. Van Overloo for anything else that I've missed.
Mr. Over.
Thank you, Madam Chair. One of the other things that is available is the appeals policy.
Hello.
So
Huh?
Wait, yes, I will address you. I think we still copying on it. Okay, Mr. Continue.
thanks. So as Minister mentioned, there is the report that's put out from the department around a lot of the details related to medical travel, and there's also a medical travel appeals policy, and that appeals policy allows individuals who feel like they haven't been provided benefits that align with the policy to put an appeal in for that, and those are dealt with outside of the administrators that are dealing with the policy. And then secondly, the exceptions policy is slightly different. It's an opportunity to look at exceptions that might not align with the policy, but can be provided to the individual on a case-by-case scenario. And you'll note in those two policies, the exceptions policy compared to the medical travel policies, there's very different language in those two policies to account for those exceptions that were discussed earlier. Thanks.
Okay, thank you. MLA to start, do you have a follow-up?
Yes, thank you. How often are exceptions made, like if in an annual period? How often are they made, and do you report on them? Thank you.
Minister Similar?
I'll turn it over to Mr. Van Overloo.
Van Overloo?
Thank you. We don't have detail here, but we could likely provide that back to the committee, the amount of exceptions that have been processed. You'll note in the presentation that the exceptions processes have been moved away. They intentionally were put in the administrative offices to allow quick exceptions related to it. And what we found is there was a real struggle to align with the financial stewardship and the policy stewardship that we have to administer the policy with, as well as identifying where we believe we should go outside of that from a patient-centeredness perspective. So there was an effort to move that away from the administration arm to allow those exceptions to be done outside. The exceptions can be sent through by the clinical team, by the medical travel team itself, the administration team, as well as by the individual. So there are many ways that somebody can send in an exception. There was intent, and I don't know if it has been, but likely in a future report there'll be a disclosure of how many of those exceptions, because that was part of the policy as well too.
Thank you. Yeah. Okay. Okay, Mr. MLA to start.
Thank you, Madam Chair. How often are appeals upheld? Thank you.
Minister Similar?
What I want to say too is, I'll pass it over to Mr. Overloo, but what I want to say is that for the review, the appeals and the exceptions are going to be kind of part of the, you know, the stuff that we're looking at in order to change the policy as well. So looking at the data that what we've been approving, and so is this something, and how do we measure that, and how do we bring that forward to make those changes? So, but for that piece, I will pass it over to Mr. Van Overloo.
Mr. Van Overloo?
Thanks, Madam Chair. Again, I don't have the exact number on a year-to-year basis. My experience, because the appeals come back to the administration arm as decisions whether or not we need to move forward. My anecdotal experience over the last 8 years under this program is very little do come back as appealed against the actual policy, and majority are usually requests that are beyond the policy parameters.
Thank you. MLA Morgan?
Thank you, Madam Chair. So far we've spoken a lot about policies that prevent escorts from traveling who want to be able to travel, but we haven't talked much about ways that we could limit or reduce medical travel for there's many people, patients who don't actually want to be traveling so much. It's a burden on them. It's hard on their health, you know. So in what ways are we considering options, tools that we could put in our system to make sure that we're reducing unnecessary medical travel as much as possible. So some examples that have been brought to me by the NMT Medical Association are use of what's called e-consult, so that clinicians in the NWT could consult with specialists down south to get more information about whether or when it's appropriate to send people down to specialists, or making sure that all of our clinicians up here, including locums or temporary ones, have really up-to-date orientation on what tests and treatments we actually have available here. Sometimes they don't even know, and they're sending people down south for things that we could be doing here. And ensuring that maybe we could even have some kind of clinical oversight or audit of the medical travel system to ensure that we're not unnecessarily sending people down south. So I wonder if those things are being considered as ways to reduce unnecessary medical travel. Thank you, Madam Chair.
Mr. Sumler?
Thank you, Madam Chair, and I'm glad that you've asked this question, because that is one of the things that we know, that there are many stories that we have heard that people have traveled and the appointment and the escort and 3-4 days to get to a specialist appointment, or it was a follow-up appointment, and it was less than 5 minutes, right? And so the one thing that I do know, and this is the thing, is that when we go and we send people down, and practitioners, when you see a practitioner in, say it's in Alberta, they're not looking at you to say, MLA Morgan from Yellowknife, or MLA Whalen Armstrong is from, Betchaco, and where is Betchaco? They're looking at it as whatever this person is sitting in front of me with whatever condition and whatever procedure they had, and what is the next recommended follow-up. I'll see you in 6 weeks, or we'll have you, and not necessarily does it need to be them. And I think that is one of the drivers that a lot of times people travel, because the practitioner is doing their job saying you need a follow-up in 6 weeks, but they're saying you come back here, but not necessarily. And it's not for like patients to know that, do I need to come back here? But it is within our system that we should be looking at those things. And, and I think the one thing is that if I go to Edmonton and the practitioner says, I'll see you in 6 weeks, and then I get a phone call from medical travel saying, oh no, well, we're going to book the doctor that's traveling into, the community that week, then they get frustrated too, right? Because they were told that they needed to go. But I think that's the background working that I think that we do need to work on. And I mean, I've said it and we've said it, and I can turn it over to Mr. Overloo, Van Overloo, to kind of talk about some of those processes that are going in, and possibly, and this is as part of the review, what we need to change in our system, and maybe it's changing some of those jobs that are triaging those systems. So I'll turn that over to Mr. Van Overloo, if that's okay with you, Madam Chair.
Mr. Van Overloo?
Madam Chair, and thanks for the question. I think this is the key topic of any health authority across Canada, is how do you ensure that care is closer to home, and it's really important in our jurisdiction as well. All the examples that were provided are being looked at across the health and social services system in some way or another. It's around ensuring capacity and priority to advance some of those. And as you heard from the minister, as more reviews happen around the reason why people are moving for care, and we find out the increasing costs of people moving for care, those are key drivers for us to prioritize some of those other areas where we're reducing the amount of travel and ensuring care is closer to home. And so I would just echo a lot of the discussion that was here today, and there are likely different places that's available publicly as well too around some of the initiatives that not only the NTHSSA but the other two authorities in collaboration with the department are moving forward with, and to ensure that individuals don't have to travel for care as often as they do, and especially in this jurisdiction as well. Thanks.
Thank you. MLA Morgan, do you have a follow-up?
Yes, thank you for that, and I'm glad it's something that is on the radar and top of mind. Are we also looking at ways that care could be better coordinated? So, for example, if there was some kind of medical travel navigator that could see if people have different appointments or be able to help coordinate appointments so someone's not going down to Edmonton for an appointment this week and then right back down next week for an appointment with a different specialist, but ways to attempt to group those together so it's just one trip. I know that's difficult because you're dealing perhaps with different medical providers in Alberta, but perhaps there'd be ways to advocate or speak with Alberta in terms of there being some kind of centralized referral or intake system where these things could be coordinated so someone could go down once and then there'd be ways for them to see the different providers or have the appointments that they need while they're down there. Thank you, Madam Chair.
Minister Similar?
Yes, thank you, Madam Chair. And I agree. I agree that it's also very complex because, again, whenever we send a referral for an outside provider, every one of those out, like if that whoever they're seeing could be, you know, if it's one hospital and the service is here and then we're sending it for, say, Glenrose, but they have appointment here, but they also have appointment at Glenrose. Do we not book one because we can't get another one for a month later? And then that holds up one appointment, you know, so it is complex. And I think for the most part, I think that's what would help when we talk about knowing who needs to travel and when, and if there's less travel happening because a lot of the stuff is happening either virtually or in their home community, then we can actually, you know, prioritize some of that. But again, it is all dependent on what they're going out for, because every time they travel out, we don't want to hold up a patient because we can't coordinate that travel to connect with another appointment that might be 6 weeks out, right? So we have to take that in account if on the severity of what they're traveling for. Thank you, Madam Chair.
Yeah. Yes, MLA Nerisu, do you have a question?
No, I'm good. I'm just taking notes and so I'm good. I'm good so far. Thank you.
Okay. Yes, I do have one too, but well, you know, I just want to ask or know if the Department of Health and Social Services are doing public awareness on medical travel insurance. Minister Similar?
Thank you, Madam Chair. We do have it on our website, and I know after it was raised in the House that I did share it with MLAs, and we have shared it with, you know, on some of the social media, on the minister's social media. But I think one of the things is that this has been my issue, I think, since I became the minister, even with medical travel, understanding the different aspects of medical travel. And like, you know, right now we have an issue with dental in my region. I mean, it's in most region, but because there was a dental office and they represent the whole Beaufort Delta and probably some of the SAW2 that went to that, it's impacting our community. But it's not an insured service, so it falls under NIHB, and that's why it's being worked on over here. It's not like we can just demand a private business to open up and hold services. And the other sense is trying to get that information out to the public. Also, there's many Indigenous people that live in communities that that work for the GNWT or another private business. They have to fall back to those insurances. And so, you know, waiting for and being able to provide the travel for any of those things. So there's a lot of different areas, and I think with the medical, I mean, I can commit here to making sure that we do have some more information and how we share that, if it's in the media, if it's on the radio, if it's, you know, to provide that if you're traveling pamphlet more, you know, to the health centers, so that they, you know, to community governments. I know the NWTAC has a really good website that they provide a lot of information, and they do emailing out to a lot of different people in the territory that provide a lot of good information. And so there is a lot that we can do. It's, you know, even though we have it on all these areas, people, like, it's like the Office of Client Experience. It's been in place for 1.5 years almost now, and some people still haven't heard about it, but I think I've said it hundreds of times, and I've emphasized this unit, but still there's many people, and it's been in the media and on the and the papers, and so there, it's how do we get. So we tried to put it out everywhere, but we can commit to ensuring that we're putting that information back out publicly again. Thank you.
Thank you. No, well, this is a really good information, especially now with the summer here, and there's going to be people traveling. A lot of people are going to be traveling, and it's really good, good information to share with our people, with our constituents, and that not everyone has access to social media, so I think printed version, a big poster-sized printed version posted in the small communities or in the community government would be, will be ideal, because that's where most of the people go to pay their bills, especially for utilities. So, so it is good. So thank you for the presentation. So if there's no more other questions, then we will end this public briefing presentation. And thank you for joining us, Minister and her staff. Thank you. So.